Here is a scene that every emergency doctor knows deep down in their bones. A patient is writhing around on the bed. They're unable to lay still, absolutely pale as a ghost with the pain. This is the textbook image of renal colic, a stone that's working its way down the ureter, that narrow muscular pipe that connects the kidney to the bladder. It has been described, at least by the men who have had it, as the closest thing to labor pain. Having seen plenty of both in my career, I'm going to diplomatically sit on the fence and neither confirm or deny this statement. Now, the classic reflex for this patient is to place an IV in the arm, give IV pain medication, and a trip down the hall for a CT scan. But what if we could relieve their agony and confirm the diagnosis without a single needle and without any radiation? And that is the question we'll be exploring today. G'day team, and welcome back to Overheard in the Emergency Room. I'm Dr. Kois, emergency physician and evidence nerd, and this is Overheard Journal Club, where I take a paper that I love, break it down, and tell you how it makes me think about the way I practice medicine. And this episode is going to be a little different. Instead of one paper, I'm pairing two, because together they sketch out a genuinely elegant approach to renal colic. One trial is about how we investigate using bedside ultrasound instead of a CT scan. The other is how we treat the pain using a nasal spray instead of an IV. Two small trials, but one big idea. Before we dive in, hit like, subscribe, and the notification bell, and head over to drkois.com for the companion blog, full references, and links to both. Right, let's go. Let me frame the stakes for you. Emergency departments everywhere are under enormous pressure to move faster, keep patients safe and happy, and reduce unnecessary risk, all at the same time. And renal colic sits right in the crosshairs of that pressure, because the traditional workup piles up three things we would love to be able to reduce: time in the department, radiation from a CT, and an IV line with intravenous medication. Each of those has a cost. CT radiation is not free, especially for the young patient who forms stones and who may come back with the next stone in a few years, stacking scan upon scan. It hurts. IV access takes nursing time, and it hurts. A long length of stay is bad for the patient and clogs the whole department behind them. So the underlying question across both these trials is the same. For the fairly typical renal colic patient, can we get the same safe result with a lighter touch? Can we swap the CT for a bedside ultrasound and swap the intravenous opiate for a squirt of medicine up the nose without missing the sick patients or leaving anyone in agony? Let's find out. Let me walk through both of these papers in PICO style. Paper number 1, bedside ultrasound versus CT. This was a randomized control trial conducted at a large, busy tertiary hospital in Seoul, South Korea. The population was ED patients with acute renal colic. They sensibly excluded people already diagnosed with a stone in the last 30 days and anyone with a fever above 37.2 degrees Celsius. So they were not enrolling likely infections, which are potentially very sick patients who will likely need an intervention. They analysed 146 patients and 128 of them had a stone. The intervention was the study design itself. On alternate days over 5 months, patients were assigned to either a point-of-care ultrasound group or a conventional group. The ultrasound was done by a mix of attending and resident emergency physicians who had completed a 4-hour education package and 10 practice cases. They scanned each kidney in 2 planes and used color Doppler to tell the collecting system apart from the blood vessels. In the ultrasound group, they were looking for hydronephrosis. That's the backup of fluid in the kidney. If they found it, a confirmatory CT still followed. The conventional group just got a CT with or without contrast up front. Both groups had standard blood tests and a urinalysis. The primary outcome for this paper was emergency department length of stay, with secondary outcomes of cost, any acutely missed or delayed high-risk diagnoses, and complications within 30 days. We'll come back to the results later, so hold your horses for now. Now for paper 2, nasal versus IV ketorolac. The second trial is a double-blind, randomized control trial in adults with acute severe renal colic, defined as a pain score of 7 or higher. They randomized 176 patients, and after a handful withdrew consent, they ended up with 85 in the intranasal group and 86 in the intravenous group. The comparison was clean and clever. 30 milligrams of ketorolac given intranasally, half a spray in each nostril, versus 30 milligrams of ketorolac given intravenously. And to keep everyone blinded, each patient also got a placebo by the other route. So the IV group got a saline squirt up the nose, and the nasal group got a saline flush in the vein. Nobody, patient or clinician, knew which route was doing the real work because of the double-blinded nature of the study. Pretty clever, right? The primary outcome was change in pain score at 30 and 60 minutes. Now, let's go back to paper 1 for the results. And the headline result was length of stay. And it was clear that the win was for ultrasound. The ultrasound group had a median stay of about 172 minutes with a confidence interval of 151 to 194. The conventional CT group sat at about 234 minutes with a confidence interval of 216 to 252. That is a difference of roughly an hour, and the p-value was below 0.001. An hour per patient in a department that never has enough beds is a huge deal. And now the secondary outcomes. The ultrasound approach was also modestly cheaper, on the order of $60 per patient. Don't forget this is in South Korea, where costs and charges to patients differ from those in the US. And critically, on safety endpoints that actually matter, there was no significant difference. There was no significant difference in acutely missed or delayed high-risk diagnoses, and no significant difference in complications within 30 days. So they saved an hour and some money without any measurable cost in missed badness. And now the results for paper 2. And this result is a really fun one. At 30 minutes, the average difference in pain score between the nasal and IV groups was 0.69, with a confidence interval that crosses 0. At 60 minutes, the difference shrank to 0.1, again with a confidence interval that crosses 0. In plain English, there was no meaningful difference. The nasal spray relieved pain just as well as the intravenous medicine. And for the secondary outcomes that reinforce this beautifully. First, treatment success, defined as a pain score below 3 at 60 minutes. This was reached by 69.8% of the IV patients and 67.1% of the nasal patients, nearly identical. There were no significant adverse effects in either arm. The need for rescue medication was basically the same, around 11% for each group. And revisits to the ED within 24 hours were nearly identical too, roughly 18% in each group. The patients got the same relief, no increased risk, and didn't have a needle and a plastic tube sitting in their arm. Now for the part of Journal Club where I stop being a fan and start being a critic. And with 2 small trials, the critic's hat matters even more than usual. So let's start with what is good. 1, both were randomized. The pain trial is even double-blind with a genuinely thoughtful double dummy design, so neither the patient nor the clinician could guess the route. That is a high bar, and they cleared it. 2, the training package in the ultrasound trial is reassuringly achievable. 4 hours of education and 10 practice cases are not difficult to achieve and should allow many ED docs to become competent. It is certainly well within reach of any resident who decides to focus on it. There is genuinely no reason a physician cannot become competent in renal ultrasound during training. 3, both trials measured outcomes that actually matter to patients and departments: length of stay, real pain relief, safety, and misdiagnoses. But what is not so good? 1, both trials are single center. That is the single biggest limitation, in my opinion. A protocol that flies at one sole tertiary hospital or at one pain trial site may not transfer cleanly to a rural department in Oregon or to a safety net hospital elsewhere. 2, both are small. 146 analyzed in one, 171 in the other. Small trials can miss rare but important harms, and they leave the confidence intervals wider than most people would like. I encourage real caution before treating either as the final word. And 3, and this is the recurring theme with any ultrasound research, the results live and die by operator skill. The sonographers in that trial had a structured education package. Your capabilities and clinical certainty will vary directly with how much you have trained. Like I always say to my ultrasound trainees, the technology is only as good as the hands holding the probe. So my honest appraisal is this. Neither of these alone is practice changing in a way that a giant multi-center trial would be. But together they point consistently and plausibly in the same direction. We can be successful with a lighter touch while achieving the same level of safety. That is a signal worth acting on thoughtfully, not a mandate to overhaul everything tomorrow. So for the clinicians, here is the workflow these two papers outline. And this is a cautious suggestion, not a protocol carved in stone, given how small the trials are. When a patient presents with classic renal colic pictures, you should dip their urine to make sure it is not infected, perform a bedside ultrasound to look for hydronephrosis, and give 30 milligrams of intranasal ketorolac for the pain. If they improve symptomatically, you could then have a proper shared decision-making conversation and discharge them on multimodal oral analgesia with primary care or urology follow-up. Follow that path and the data suggests you would achieve adequate pain relief by 60 minutes in around 70% of cases. No needles and no radiation. Many patients would see that as a genuinely appealing package. The harder question is the flip side. Who needs the CT scan? To my mind, that is the patient whose pain does not settle by 60 minutes, the patient with any sign of infection, and the patient with a complicated renal history, prior nasty stones, a transplant, or anyone who simply looks sick. Those are exactly the people the light touch pathway is not designed for, and you probably should scan them. I'll be honest, in real life, I do not always manage the bedside ultrasound because competing priorities in the department pull me away. But in a world where we are increasingly assessing patients straight from the waiting room, I think there is real merit in the scan and spray approach for the right patient with renal colic. And if you are listening as a patient and you come in with a kidney stone and your doctor reaches for a bedside ultrasound and a nasal spray instead of an IV and an immediate CT, that's not a shortcut or a lower standard of care. For the right patient, evidence suggests it can work just as well, spare you radiation and get you home sooner. A perfectly fair question to ask is, do I actually need the CT, or can we start with the ultrasound? Sometimes the answer will be you do need it, either because the operator isn't confident in their ultrasound skill or it's simply not available. And that's fine, but it is a reasonable request. So here are your 3 takeaways from today. 1. In one randomized controlled trial, using bedside ultrasound for hydronephrosis instead of an upfront CT reduced emergency department length of stay by about an hour, saved a bit of money, and did not increase misdiagnoses or 30-day complications. 2. In a separate double-blind trial, intranasal ketorolac relieved severe renal colic pain just as well as intravenous ketorolac, with the same safety and no needle required. 3. Put together for the right patient, you can consider a scan and spray pathway. Dip the urine, ultrasound for hydronephrosis, treat with nasal ketorolac, and reserve the CT for those who do not settle, who look infected, or who have a complicated history. Both trials are small and single center, so act thoughtfully, not reflexively. If you got value from this, please like, subscribe, and hit that notification bell. Drop a comment with the next paper you want me to break down. Listener requests always jump the queue. And share this one with any resident who wants an excuse to get better at renal ultrasound. Head over to drkois.com for the companion blog, full references, and links to both papers. I'm Dr. Kois. Let's keep chasing fewer bad days and more good decades together. See you next time, and hopefully not in my emergency department.